me go ahead one sec.
Yeah, let's do it.
Hi, everybody. This is Gene Ransom with MedChi, and we are starting the EQUIP Primary Care subgroup meeting. And Chris is going to be presenting today from the HSCRC and giving us what I would consider really good news, right, Krista? And an update on
Yeah,
where we are. So, Krista, it is all yours. Just
absolutely.
let me know what you need.
Okay. Thanks so much, Sheen, and good morning, everyone. We are pretty excited to share this information today, and we'll take questions at the end. But of course, send questions through the chat as well, and we'll do our best to answer as we can. Next slide. There we go. So today we're going to do an overview of the RFA, which we hope to get out this Friday or Monday. Still working out some kinks, but we're really excited to announce that the RFA will be released. And just going to give some quick background for folks that may not have been on the calls before. Just a reminder that CMS approved a one-time reversal of the MPA Savings Component, implemented January 2023 for calendar year 2023. And the state set aside the majority of this amount to fund targeted investments. I'm sorry? In primary care to fund target investments in primary care in Maryland, really to improve the reach and effectiveness. So there's 19 million for EQIP PC, and it is expanding primary care availability in underserved areas of the state. Next slide. So the state is seeking applications from interested organizations for this program. And basically the program is providing startup infrastructure funding in return for adding at this advanced primary care capacity in designated areas. And this is a 5-year pilot program at this point in time. And again, the focus of the program is to increase access to advanced primary care. And the funding period is noted here, CY25 to CY 2029. And the proposed program measurement start date is January 1, 2025. Not very far away. Next slide. And again, these are components of the RFA. So once you see the RFA, this will make a little bit more sense, but this is kind of the administrative structure and program support. So EQIP Primary Care will be organized under the sort of banner and framework of the existing EQIP program. EQIP Primary Care is not a bundle payment program. It's just organized under EQIP for administrative purposes. And it will have very unique characteristics and has unique characteristics from the existing EQIP program. And the state will provide program support through our existing tools, such as CRISP, the MDPCP PMO, and HSCRC. Next slide. Eligibility. So again, some of this is a bit redundant, but the state is seeking organizations for this multi-year commitment. Eligible organizations include existing practices who commit to adding new providers in these designated areas, which we will go over in a bit, completely new bricks and mortar practices, and organizations such as a large employer or local government who would then sponsor an advanced primary care practice. And these organizations may include MDPCP and non-MDPCP practices. And EQIP PC really is supplementing MDPCP. This is, as folks are aware, MDPCP is focused on funding existing primary care, and EQIP PC is focused on the expansion and creation of new access to advanced primary care. And the state envisions EQIP PC as really an on-ramp or pathway to MDPCP. Next slide. Okay, so focus areas. These are the geographic areas of the state. And this slide, it just kind of goes over how we designated the focus areas. We have designated certain geographic areas in the state that are a mix of rural and urban areas, and we will select the best applications using a panel of technical experts, and really trying to find the best applications that address the needs of these focus area populations. We have identified zip codes where there's a low supply of primary care and poor health and social outcomes. And the state has determined the geographic areas of the state where the program will be focused. We'll go over that in a second. And we use the following measures as a way to determine what those areas are using HIPSA, PQI, and ADI, which folks may or may not be familiar with. These are live links. You can feel free to click on those in the deck. Next slide. So sharing this slide with a caveat that we are doing a kind of reanalyzing the data. Someone has brought to our attention, thank you, something that will likely increase the number of zip codes that are included in the focus areas. So this will change slightly, and we will share that hopefully within the coming days, and that will be in the RFA when it goes out. So a revised map with revised zip codes will be included in the map. And we will, maybe we can plan to share that, we'll plan to share it in the RFA. If we get that sooner, we could potentially send it out to folks if they're interested, but nonetheless, it'll be in the RFA. Again, not necessarily taking any zip codes, but potentially adding zip codes. So it would increase the number of focus areas that are included in the state. Slide. Okay. I'm gonna feel like I'm talking really fast. I'm gonna slow down a little bit. So the model of care, I think folks are familiar with. This is really about providing a pathway for access to new high quality care delivery. And the application practices will describe their model of care and how it aligns with this primary care framework outlined below, using the three main components of care management, integrated care, and community linkages. So we will be interested to see, for example, under care management, how they will build care management and chronic condition self-managed support services, how they will leverage existing programs, in terms of integrated care, how are they strengthening connections with specialty care clinicians, how will they utilize evidence-based behavioral health screening, things like that. So how are they aligning with this model of care? We're not asking for exactly what's here, but how are they aligning? What are they doing to leverage this model of care in their primary care practice? And then as well, community linkages, how are they identifying and addressing health-related social needs? How are they building partnerships in the communities? Are they creating MOUs with community-based organizations, things like that, and as well as partnering with FQHCs and other safety net providers. So we'll be looking to see how folks align with this model of care. Next slide. Financial goals and funding. So all EQIP primary care proposed startup funding is supplemental to normal revenues. Providers are expected to bill all payers, including Medicare fee-for-service, as appropriate under standard reimbursement practices. The specific nature and amount of the funding that will be available under EQIP PC will be determined based on what applicants submit in the funding proposal worksheet, which will be a part of the RFA package, and that will make sense once you see it. It'll be an Excel worksheet, and the organization that's applying will indicate how much funding they need for the infrastructure costs that they're proposing to need as part of the startup of the organization, or to add additional providers to their practice. There is no restriction on practice's ability to participate with other payers or serve non-Medicare fee-for-service beneficiaries. There are no restrictions, anything like that. And practices may use the funds from this program on activities related to infrastructure development and for the care of all patients in the practice. So this infrastructure funding is really for the totality of the practice, not specific to a population necessarily or payer. Next slide. The funding streams outlined below. So the infrastructure payment, as we've discussed, is available the first 2 years with the potential for expansion to years 3 to 5, depending on the applicant and what resources they're bringing to the table, what they need. Annual payments are made to practices in the last quarter prior to each program year. The beneficiary payment is available years 3 through 5, and that structure will align, the payments for that will align with the Medicaid Advanced Primary Care Program and MDPCP. The Medicaid Advanced Primary Care Program is what we're proposing under the AHEAD model. More to come on that, but we just want to make sure that the incentives are aligned across and not competing. So just wanted to note that that will be an important component of the beneficiary payment. And the specific amounts have not been finalized. Practices are going to be asked again in that Excel template to include their assumptions about the per beneficiary amounts that they will need to in establishing their request for the infrastructure payment. So we're looking to see how much infrastructure money you're asking for, and how do the beneficiary payments, what their assumptions are about what per beneficiary amounts will be useful given the amount of infrastructure payments that they're asking for. And practices can kind of look to the payment levels under MDPCP currently as guidance. So looking at MDPCP per Benny payments and the payment methodology for MDPCP along with your infrastructure dollars, you can kind of get a feel for, we're interested in folks getting a feel for what that infrastructure payment will look like, taking into consideration those amounts. And I think that will make more sense when folks see the funding template. And the shared savings, again, pretty straightforward here, available years 4 and 5, upside only, and further details of this will be available later to align with Medicaid, the Medicaid primary care program, or the program in theory that will be under AHEAD and MDPCP. Next slide. Attribution, this has been pretty straightforward, has not changed. Beneficiaries will be attributed to a primary care provider when that Benny has their first claim for an annual wellness visit or welcome to Medicare visit during the performance year. There are no restrictions based on prior eligibility, and there is no minimum attribution requirement at this time. So we want to keep this straightforward and as simple as possible. Next slide. The participation requirements, new sites and providers will be required to participate in Medicaid and or contract with at least 2 managed care organizations. Practices must be in one of the tier 1 or tier 2 focus areas on the map to participate. There should be a bullet there. Sorry about that. Participating practices are required to identify a lead care partner who will sign the agreement with the CRP entity and comply with all applicable requirements. This is similar to how it is done in EQIP. Folks might be familiar with that. More to come on that. The lead care partner will not have to participate in EQIP PC, but the lead care partner will need to meet all CMS vetting and certification requirements as outlined in this document. And this structure is really, at this point when we're having, this will be before potentially clinicians are brought on or the practice has started. So this lead care partner really is, they're signing the agreement. They don't have to participate, but at that point, we don't have clinicians necessarily. We may or may not. So they are sort of serving in that role until we have clinicians in place and the practice in place. Next slide. MDPCP interaction. So MDPCP practices, again, will not be eligible to receive the per Benny payments. They'll be eligible for infrastructure payment and shared savings. We believe that there's duplication across the per Benny payments. And transition to MDPCP and the Medicaid Advanced Primary Care program will be required at the end of the pilot as appropriate, given head negotiations and what happens with the Medicaid primary care program. And practices can transition to MDPCP sooner as appropriate. And then existing MDPCP practices will be expected to continue at MDPCP. So you can't drop out, in theory, from MDPCP to join EQIP PC. We are not allowing that under this program. Next slide.
What happens if the practice isn't eligible for MDPCP? They don't meet the 250 attribution, or for some other reason they can't get in. How is that enforced? Is there any kind of penalty or anything if they are not eligible? Is the goal just to have them make a good faith effort to participate, or have we not worked that out yet?
I think if we haven't really talked about that specifically, I think we would take, kind of look at that on a case by case basis. We would want them to transition. Thank you, Howard. Yes, 125 is the minimum for MDPCP. So hopefully folks can meet that after the 5 years. But yeah, that's a great point, Jean. And I think we'll have to work through that with practices. Hopefully they'll be ready to make that transition at 5 years.
Yeah.
Hopefully, I would hope. Who knows?
Let's hope
Program,
MDPCP is still here, right? So
right.
yeah,
Right.
anyway, all right.
Okay, program compliance. So to ensure ongoing compliance, the state is going to be developing some program monitoring controls that are including but not limited to the following items. So these are pretty standard. So meeting all CMS vetting and certification requirements. We're going to be monitoring the net increase in primary care capacity in the geographic focus area. So we'll be looking at that to make sure that is a thing that is actually happening in these new EQIP PC practices. Thank you, Chad. We'll be doing audits to ensure program integrity. For example, review of annual wellness visits for upcoding. We'll be developing a quality monitoring framework in conjunction with stakeholders and practices that are participating. Similar to MDPCP, we want to align with MDPCP as much as possible, and that will start in year 2. We will be very interested for practices to really demonstrate fidelity to the model of care. Like I said, aligning to the extent possible, to the extent that it makes sense for your population. And we'll be looking at certain operating requirements. Sorry, this should be a bullet. We'll be assessing these items using an annual progress report. So more to come on that. We will be looking to not make this overly complicated, but we want to be able to assess certain items to make sure that the funds are being used appropriately. And again, increasing the primary care capacity in those focus areas is critical. And again, failure to comply with these controls after allowing for a reasonable corrective action period will result in either a reduction of the funding or practices being eliminated from the program. But we really want to keep these practices in, and we'll work very closely with them to make them successful in the program. Next slide. So just quickly, the vetting and certification of care partners. Each care partner that is operating within an EQIP PC practice, as I stated earlier, must meet at a minimum the following requirements. Must have an MPI, must participate in Medicare, must be licensed, must use at least 2015 cert, and then providers will be subject to federal program integrity screening process. And the vetting and certification will occur at least on a quarterly basis. Next slide. QPP eligibility participation requirements. So folks are probably already aware of these requirements. So through the federal vetting and certification process required for CRP, as existing CRP care partners may be eligible to become QPs or qualifying APM participants. They could opt out of MIPS they can opt out of MIPS if they're in one QP snapshot or eligible for the year and certified as QPs. HSCRC will update methodologies to ensure alignment with the QP thresholds in QPP. So continuing kind of how things operate currently under EQIP, we'll be following the same sort of QPP standards for EQIP PC. Next slide. Again, this is just a kind of overview of the application and evaluation. So interested organizations will apply. Once we release the RFP, we'll include a narrative template, the funding proposal worksheet, as I described, the Excel template, and we'll be looking for a work plan, short and long-term milestones, including timeline and staffing model. And this will be all outlined in the RFA in more detail. These components will be required for submission. And we are currently putting together an evaluation committee formed by the HSCRC and will review and score the program applications. And those committees will include primary care experts, staff, and other stakeholders. And we will make the awards based on the applications that are received, and we'll determine how the funds are dispersed. Once we have all of the applications and have made those decisions, the funding will be determined. Next slide. This has not changed. This should be familiar to folks who have been on these calls. Applications will be reviewed and funding awarded based on the following criteria. And this is laid out in more detail in the RFA. We'll be looking at the background and the qualifications for delivering high quality primary care. We're interested in, do they have knowledge and presence and experience in the geographic focus area? Also understanding that this is an underserved area currently, so there may not be a presence in the area, taking all of that into consideration. We'll be looking at women minority status, the model of care alignment, what the staffing model looks like, what the strategy is for recruitment of clinicians into these underserved areas, which we know will be a challenge. Are they in the focus areas? What we mean by location desirability, that will be critical. And then, kind of the care coordination and practice support function. So do they plan to work, how do they work with an entity such as like a CTO type entity to provide care coordination? Like, how are they providing these critical aspects of the model of care? Is there supports, are there supports in place to support data analysis and the data infrastructure, things like that? So we'll be looking at that as well. And again, that'll be outlined in more detail in the RFA. Next slide. The timeline, this has definitely changed since last time. So folks, please take a look at this in detail. We will be releasing the application hopefully this Friday, if not first thing Monday morning. And then there'll be a period between June 28th and July 15th where folks can ask questions. We'll set up time to speak directly with organizations, or we'll do it through this, the EQIP subgroup meeting. And the deadline for the program application will be August 11th. And then there will be, the review panel will be evaluating the applications, and successful applicants will be notified in September. Selected organizations will complete enrollment through September and October. Vetting and subsidy payments are made in the November, December timeframe. This is a little bit more compressed than it was originally. Forgive us for that. And then January 1 will be the EQIP PC program measurement start date, as I mentioned before. And next slide. Okay. There's a link to our website hosted by CRISP, and any questions can be submitted to myself or through the total cost of care mailbox noted below. And we can take any other questions that have come up. Thanks, everyone.
And Krista, in the chat, there were just two comments, again, correcting me on messing up the attribution from DPCP from Dr. Haft at 125, which you did immediately. And then secondly, Chad Perman says to be determined, but I think Medicaid is working on a pathway that all practices that want to participate in Medicaid APM will have a pathway. So that was just for information. Are there any other questions on the RFA, where we are? Anything else anybody wants to bring up? You can either put it in the question answer or in chat. Also in question answer, the question was, what was CRP? And CRP, of course, is Care Redesign Program, which is what EQIP is, or CTIs if we're the hospitals or others. Dr. Motormast, go ahead. The floor is yours.
Thanks. Good morning or afternoon, everyone. Great to see you. Thanks for this wonderful information. Question. At the time of the application, I'm assuming probably when people are informed that they've been accepted into the program, will they be told the amount of money for infrastructure support that they will be given?
Yes, I believe, yes, at that point in time, once we've decided who the organizations are, we will have determined the amount of payment that will be offered.
Will we also,
go ahead.
Sorry to interrupt.
No, go ahead.
Will we also be telling them if they're eligible for that 3 to 5 year extension rather than just the 1 to 2 year timeframe of support?
I believe that we'll be kind of assessing that on an annual basis, depending on how the practice is doing. If they're, kind of struggling to get momentum, we would reevaluate that on a yearly basis. So,
and will that level of detail be given to the practices so they know what they're signing up for?
And you mean level of detail in terms of the amount that could be available to them in the years 3 to 5?
Like what the threshold for struggling would be?
Yeah. What is struggling? I think we have yet to flesh that out, but I think that would be something we'd be interested to kind of talk with stakeholders about, like, what does that look like? What do we think that? I mean, I think some of that is, what does their panel look like? Kind of what are they planning to keep the clinicians that they have on board? Do they want to add new clinicians? Are they really are they kind of what are some of the basics of the practice? Are those things happening? But yes, I think we need to flesh that out a bit more.
It's William Henderson from the HSCRC. I think I would just add to what Krista said. I think that's part of the reason we're asking for that work plan and stuff in the RFA.
Yep.
That will probably become the skeleton for evaluating the practice on achieving those goals, right? We may ask you to flesh it out further, or we may want to change things slightly, but I think we would view that will be the starting point for the goals that we would then evaluate on whether you would continue to be eligible for the funding.
So,
right. Thanks, William.
So Will/Krista, I have a follow-up question on that, if this is okay. Since we're obviously prioritizing and focusing on and only going to fund new primary care, some of the groups might need the money up front. When do you see the money being released so they can make the investments and get moving?
Those payments will go out, I think I said in the site, is it like 1 month before the start of the program year? Or
December 1.
Yeah, I think our goal is
around.
Yeah, that quarter before the year. So if
Quarter
you get,
before,
$500,000 for year 1 and $500,000 year 2, we would look to cut those checks in November, December of the year before that year.
And obviously one of the things whoever's applying is going to have straight is they're going to need a lead care partner who can meet the requirements and apply for EQIP appropriately. Obviously, a lot of groups would be hiring based on getting the money, so it's probably not going to be the practitioner they're considering. So most of these groups are going to need a medical director or a physician lead or a practitioner lead to fill the application out. And that's something they're going to want to consider when they're doing the application as well.
That's right. Yep. Thanks, Jean.
Yeah. I'm just saying from a practical point of view, if you're trying to get this together and get it turned in, and you're thinking about how to piece it together, because one of the things we don't want to have happen is we just don't want only groups that have large amounts of resources applying. That would defeat the purpose. So we just need to think about that as about flexibility and how we help smaller groups with less resources participate.
And I would say that's also when, if smaller groups are interested in applying, reach out to us, reach out to Jean so that we can assist in that process and help you figure that out during that question and answer kind of period of between June 28th and July 15th.
Any other questions for the good of the order from anybody?
Jean, Stuart Sutley, quick question. I just want to reemphasize or have you reemphasize one point you just made. So when the application is being submitted by August 11th, there needs to be that identified clinical lead, because they're going to have specific parts of the application that they personally will need to fill out.
Yeah,
go ahead, Jean.
I don't know if you, Stuart, because I know you guys have, I don't know if you have any of your practitioners in the Meridian Health thing that you're doing now in EQIP, but essentially it's like being a lead care partner for EQIP, where that person would sign up and go through vetting. So yes, there would have to be so if one of the existing practitioners at maybe your facility in one of the places, maybe Hagerstown, for example, I know you're doing one there. If that practitioner was the lead care partner for wherever you were adding something new, that would be fine. And then your application would say, we're going to hire 3 primary care physicians and we're going to whatever. So but yes, you're going to have to identify somebody. Sorry, Krista, did you want to? I didn't mean to.
Yeah, no, that's actually, I think I don't think we specifically ask currently, like, have you identified someone, but I think that would be something we'd obviously want to include in the RFA. So you'll want to have that person in mind. I don't think they're filling out anything specifically necessarily in the application, but you'll want to have that person identified, and we may need to kind of rethink the application just to make sure that that's something that we call out. So yeah, nothing really to add there.
Krista, from a practical point of view, they will have to have that person, that human, under agreement if they're approved by that September to October time period, because they'll have to go through vetting. They'll have to
absolutely
sign up with CRISP. They'll have to go through CMS vetting. So it's something that if you're doing this, you should be thinking really seriously about it, because you will not be successful if you don't have that human in place.
100%. Yeah.
Yeah, the
But
hard
that
deadline
doesn't
is
have to be
really,
the person who's providing all the care. In fact, it's not
Exactly.
expected that it would be. So I saw Dr. Trumbull on the call from Title. If Title did one in Lower Shore, he could be the lead care partner for the EQIP entity. And I think he might be a care partner in one of the EQIP bundles right now, possibly. But my point would be that would make sense. And then they would add the new physicians or hire them for the project if they got the grant, right?
yep.
Yep.
Yeah, I think the hard deadline is September 21st. If you didn't know that person on August 11th, I guess that would be okay, but it's
Right.
obviously, I don't know what that scenario is where you know them on September 21st and don't know them on August 11th, but
Right. And I was just saying that I don't think we call that out specifically in the RFA, like who is that person identified, but like William said, I mean, the hard deadline is for that September vetting. That person definitely needs to be in place or decided upon at that point in time.
And if you have questions about that, particularly if you're using someone who's administrative in nature, there are things that you'll want to make sure, like, you know, do they participate in Medicare? Is their PCOS up to date? If you want to call MedCai, or reach out to Krista or Jessica, Chris, or somebody, we can help you with those things. But I would just be cautious, particularly if you're picking somebody maybe who isn't regularly practicing, that they actually will make it through. They're going to need to participate in CRISP. So anyway, we can go through that and help anybody who needs help with it, but we don't want that to be a barrier from success.
That's right.
Thank you.
All right. Any other questions?
Yes, sorry, it's me again. We're just wondering how we're going to advertise for this program. So if we're thinking about building primary care practices out, and maybe we want to get it out to individual practitioners that might be interested in this, how are we going to share that information? I'm specifically asking because I want to share it with the MDPC or the Maryland primary care physicians, but is there other ways we'll be advertising for this?
Absolutely. I think number one is that I am working with Chad at the PMO to make sure it gets out to those stakeholder lists and the MDPCP listservs first and foremost, and then our kind of, EQIP PC subgroup distribution lists. I think we can distribute it to any list that folks, I know, Jean, you have a distribution list as well. So we'll be getting it out through those channels. Any other ideas, I think we're open to. We'll probably post it on our website as well. And we could probably send out something to that broader group. William, I don't know if you have any other thoughts on.
nope, I think that's my list. We will probably,
Yeah.
we could get it on the commission agenda just to be announced, probably for July. So yeah, but if anybody else has, please feel free to forward it. Everybody on this call will get it because it'll this distribution list, and please feel free to forward it to whoever you think is appropriate.
And we'll push it out through all the MedCai channels. We will obviously, and this video will be loaded up today, and the slides will be up on the web today. So we'll have both that up and out, and that and Dr. Motormass, if you'd help us share it with the Maryland Academy of Family Physicians, that'd be great. But I think we just want to push it out to everybody. All right.
Is there like a one pager or an infographic or something that would be easy to get out and they don't have to say, oh, PowerPoint, maybe I'm not interested in that, but could be something that's a one pager that gets their attention?
You know what? We don't have one, but maybe Will, Krista, we can talk about doing a press release on the page, or maybe we can figure that out. That's a good suggestion.
Yep, I think we can do that. That's a great point. And
but we can do a press release too. I don't see any reason why not, if that would be helpful. You know, if it's a problem for the state to get it approved, we could just have MedCai send it out. Okay.
Yeah,
I think a one pager is a great idea. Yeah.
All right, Dr. Bazinski, you have your hand up.
Hi, thanks. Sorry, I was with patients and just got here. Yeah, I think that, if one of our goals is to bring new providers to the state and bring new primary care to the areas that need it, maybe even considering some of the adjoining states, internal medicine, primary care, family medicine, pediatric, maybe some of those medical societies in adjoining states. In case somebody's interested, like, I look at the one site, it's in Cumberland, that's just a few miles from both West Virginia and Pennsylvania borders. We have to providers in this area who do live outside of the state and practice in Maryland. So if we're really trying to drive new practices, new providers, then, a lot of things that's been mentioned so far, are people who are in the know. You know, people are connected to Maryland in some way. And, you know, I mean, if we really want to be optimistic about this and bringing new providers to areas that are underserved, that might be something to look at as well in terms of, you know, networking with regional physician organizations or other, you know, organizations that might be willing to help stand up new practices.
That's a good suggestion, Dr. Brzezinski. I'll make sure we send the materials to my colleagues in Delaware, Pennsylvania, West Virginia, and Virginia, and DC. You know, we tend to be a net exporter of physicians. It'd be cool if we actually stole a couple.
Yeah, yeah, I hear you.
Katie, Venice. Your turn, Katie. I feel like we spent all morning together. You're on the total cost of care earlier. Are you muted or was it an accident? You're muted right now.
Frozen.
Oh, frozen. Oh, okay. We'll see if she gets unfrozen. Anybody else who wants to ask anything? All right, Katie. You may have to reach that back out to us offline. Anything else for the good of the order, Krista, Will?
I don't think so. Just stay tuned for the release, and thank you everyone for distributing that to your colleagues and other folks. We really appreciate your help and your assistance in sort of developing this program, and you know, all of your feedback has been really, really useful. So thank you very much, and thank you for all of your commitment to this.
All right. And I saw Chad putting the sending it out to all the licensed physicians. I'll talk to the Board of Physicians about that and see if we can make that happen. I'd be surprised if Christine said no. And I see Katie's trying to come back in, so maybe we'll give her one more shot to ask her question. She usually asks good questions.
Can you hear me now?
Yes, there we go. We can hear you.
Hi, my apologies, network connectivity. The one thing I wanted to raise, and I thought that the last point was excellent about coordination, but I just want to do a check here that it would be funding for this is primary care funding for the health of Marylanders. So I don't think we would want to be in a situation where the funding was going across borders. I just want to make sure I understood that last question correctly.
No. I think Dr. Brzezinski was talking about convincing doctors to move to Maryland.
That makes sense.
That was how I took it. That was my, so.
Yep.
Yeah.
That is my, you know, we all look at things from our own lens, and I moved here to another state, and I'm like, how in the world would I have ever, if I was coming in 2024, how would I ever hear about this program? Like, you know, no doctor goes and just follows what the HSCRC is doing.
Right.
I mean, we love you guys, but you know, like, you know,
That's an excellent,
getting a
that's
license.
excellent point. And you know, we have some of the lowest reimbursement rates for physicians in the country. So to the extent that we can attract physicians to come to Maryland to provide supplemental revenue streams to do the population health care that we're looking for, that's a great pitch for that. So great point. Thank you.
Yep, just need another sucker like me who doesn't know about the low physician reimbursement for 20 years.
You know,
Let's not advertise that.
Ken, you raise a really great point. You know, and I think, you know, particularly besides wanting this program being excellent in establishing care, advanced primary care in underserved areas, it also helps support independent physician practices, and something that the American Board of Family Medicine is really strongly supportive of. And it might be something that can pass on this information to them. They might be able to even more broadly extend those kind of opportunities. So great, excellent point.
Yeah, that's a good suggestion, Dr. Half. That won't just reach out to the medical society. I'll reach out to national specialties too. That's a really good suggestion, actually. So, and if we could get a couple more Dr. Brzezinskis, I would do that every day of the week and twice on Sunday, man.
I've been trying to get more, and it's hard. You know, I'll tell you what, though, you know, no one really outside the state understands we have a different funding system, and to start talking about these things at the regional and even national level, you know, I think we got to toot our horn a little bit. You know, where else in the country are people giving actual cash money to start primary care practices? Like, this is pretty good work that's going on here. You know, we've identified reimbursement issues, we've identified access issues, equity issues. population health issues, and we're taking real multi-million-dollar strategies to improve it. And I just think that it's valuable to represent that, beyond just our borders, beyond just to the already engaged stakeholders, to really say, look, there's alternative ways to do healthcare, and we're trying in Maryland, and some's good, some's bad, but it's a dynamic environment here, and I think that's a positive for our state as a whole.
And what better note to end on than that? That's perfect. So unless there's anything else from anybody, we will go ahead and end the meeting. Is that good? All right.
That's great. Thanks, Jean.
Thank you, everybody.
Thank you, everyone. Take care.
All right, have a good rest of your week and a happy 4th of July.